A 47-year-old woman has been experiencing a 4-month history of diarrhea and bloating, and hemoglobin is 9.3 and MCV is microcorpuscular. A microcorpuscular volume is microcytic, and biopsy is being shown to you. Foamy macrophages immediately remind you of celiac disease. So there you will do anti-tissue transglutaminase antibodies positivity is a very classical feature, is what need to be remembered. A 21-year-old with painless hematuria, he suffers from type 1 diabetes and he had a mild throat infection recently. Synpharyngitic hematuria is the name which is being given for IgA nephropathy. Unlike post-herpetic glomerulonephritis, where sore throat is followed after 3 weeks by hematuria, that is PSGN. Sore throat within 2 to 3 days with hematuria is IgA nephropathy, is what you have to basically remember. Then 74-year-old type 1 diabetes, and post-operatively patient is on insulin and IV dextrose, and 2 days after the operation she is very agitated and delirious. Sodium is 124. 124 ka matlab hyponatremia, and glucose is around 7.2 millimoles, which is hyperglycemia. Serum osmolarity is 265, which is hypoosmolarity, and urine osmolarity 150. Then what is the most likely cause of the hyponatremia? Hyponatremia causes have been divided into euvolemic, hypovolemic and hypervolemic. So once more, hypertonic and hypotonic causes. That's how we need to differentiate. So whenever there is a water overload, that lead to development of a dilutional hyponatremia. So whenever the water overload is there, what will happen? The plasma osmolarity also is diluted, and all that water passes into the urine, so even urine osmolarity also is low. When both the things are low along with hyponatremia, we should think of a water overload as an underlying cause, is what need to be remembered. Now, a 16-year-old boy with low-grade fever, and the patient also reports feeling fatigued, and there is a pain into his joints, and his parents mention that he has been visiting the toilet very frequently. There are trace proteins, and there is a raised eosinophil count. The most important clue is the raised eosinophil count. So whenever eosinophilia accompanies the glomerular dysfunction, renal dysfunction, you should contemplate the possibility of tubulointerstitial nephritis, is what you have to basically remember. Can the online students can check whether the voice is loud and clear without freezing? Yeah. So a 42-year-old diabetic Asian male complains of dysuria with increased urinary frequency. Can you give me the board, please? Yeah. No, not board. Give me the camera. But is the voice, please put the voice and listen, sir. Yeah. So examination of the urine is being shown in the figure. So what do you find? A lot of neutrophils. That is called pyuria. Presence of a lot of neutrophils. But the urine did not grow any culture of organism. And what is that called? Sterile pyuria. So when will you get sterile pyuria? Whenever the renal infection is because of bacteria, then the urine culture will grow organisms. If the renal infection is due to TB, then that will cause a pyuria, but the regular bacterial cultures cannot grow the TB, tubercular organism. That's the reason. What is that situation called? Sterile pyuria is what you have to basically remember. Now, a 28-year-old woman patient who is 13 weeks pregnant comes to the antenatal clinic, and she feels embarrassed to provide a urine sample but you have done a urine dipstick test which is positive for leukocytes and nitrates. The patient denies any symptoms. So in this given scenario, what is the best treatment that you want to give? So whenever there is a bacteriuria, nitrate positivity on dipstick is suggestive of bacteriuria. But clinically patient is not symptomatic. But in case of a pregnant woman, unless you treat the asymptomatic bacteriuria, there is a great chance that the patient can end up in a preterm delivery. So that is the reason we have to treat the patient, and the treatment of the patient would be by administration of cephalexin is what you have to basically understand. Now a 64-year-old woman with type 1 diabetes, 4 days history of oliguria, blood pressure is 137/80, ANCA is positive, RBC casts are there, and the renal biopsy has been done. So what do you see in the renal biopsy? Crescent formation is what you are able to classically see in the renal biopsy. So it is a typical case of Wegener's granulomatosis is what you need to basically understand. Now a 49-year-old woman who has got chronic renal failure due to a progressive glomerular disease, elevated phosphate, serum creatinine and urea, and calcium levels are low, and her estimated GFR is given, and typically in this given scenario, what is the best management you want to do? So typically the patient is suffering from renal failure which has landed her in the state of hyperparathyroidism is what you need to basically remember, and that explains her abnormal calcium and phosphate. That hyperphosphatemia can lead to vascular calcification. So that is the reason we need to give a phosphate binder like sivalamer in order to basically capture that hyperphosphatemic state is what need to be remembered. A 60-year-old with tiredness, weight loss over a period of 6 months, and typically a penile lesion has been shown, and what is it showing? Candidiasis. So whenever candidiasis, penile candidiasis is there, you should always check for an underlying immunocompromised state, and that would be diabetes is what need to be remembered. Typically a necrotic pattern has been shown. What is this called? This is called a liquefactive necrosis. Whenever liquefactive necrosis is there, what is the underlying cause? It is a type of liquefaction pattern in the brain. So it occurs in brain, and you have got coagulative, liquefactive, etc., etc. You must know in which situation we see. Necrosis is one of the favorite topics in types of necrosis in pathology. So already we finished DNB, AIIMS and All India. All the 3 question banks of pathology last 15 years have been thoroughly reviewed and made available in our online video library anatomy2medicine.com by Dr. Kulkarni. Dr. Kulkarni sir is like Sri Mahavishnu for pathology, right? So only knowledge and knowledge only in its purest form comes out of Dr. Kulkarni sir. So please don't miss that. Now a patient is being admitted with fever, sore throat, conjunctivitis, skin rash, and transbronchial biopsy has been done. And what do you see? This is actually a pickup from APPG 2016 question paper. 16 or 15? 15. Last year 16 one. Huh. So these are the Warthin-Finkeldy cells, which are the typical features which are seen in the case of the measles is what you need to basically remember. Now, typically what are these features? You are seeing bite cells. Bite cells are the histopathological feature which you see in case of the G6PD deficiency. A newborn has got polyhydramnios and aspiration pneumonia, excessive salivation, and a radiograph has been taken, and whenever you try to pass a Rayleigh tube, it is curving upon itself, and classically it's a tracheoesophageal fistula with esophageal atresia. So that's what need to be identified. Now an endoscopic appearance of the stomach has been given to you. There is a mass lesion, and histopathology has been done, which is a classical thing about lymphoma. So typically it is a case of gastrointestinal tract lymphoma is what you need to basically appreciate. So if you take the gastrointestinal tract lymphoma, most of the times it is a mucosa associated lymphoid tissue from where it is originating, which is caused by the H. pylori, and it is more amenable to the treatment than the gastric adenocarcinoma is what you have to basically appreciate. A 65-year-old has got a crushing chest pain for the first time, and he had been transferred and a PDCA has been done. So some of you today are preparing for entrance exam. Tomorrow you will become MD General Medicine, DM Cardiology, and a very busy interventional cardiology practitioners. So that time probably I'll come with a lesion like this. Don't make a wrong diagnosis, be very sure. That's the reason for my own personal protection I am trying to offer you good questions which are well researched. So it is a left anterior descending artery which has been occluded. After stenting there is a good flow. So left anterior descending artery typically reflects as a ST segment elevation in left sided leads. What are left sided leads? Lead 1, AVL, right? V5, V6, these are all called left sided leads. 2, 3 AVF are called inferiorly looking leads, right? V1, V2 are right sided leads. That's what you need to basically remember. So there is a 3 hours of quick review video on ECG in the anatomy2medicine.com video library. So please review that. Invariably 4 to 5 questions on ECG will be there in the NEET PG paper, right? So at least if you know some basics of how will electrolytemias, dysregulitemias, hyperkalemia, causes of QT prolongation, what is the normal QT look like, how to calculate the rate, axis, causes of left axis deviation, right axis deviation, how will left atrial hypertrophy look like, enlargement, right atrial enlargement look like on the ECG. Few basics. Hardly there will be not more than 20 standard ECGs in the general medicine. So that 3-hour video, even it is available on YouTube. If you don't have access to the anatomy2medicine.com, it is available on the YouTube. You type ECG, Dr. Murli Bharadwaj on YouTube. You have got, every day we will be putting some other video. Almost education is free on YouTube. But that makes a lot of students actually recognize us and come and join our courses. Okay, honestly nothing is free. So 78-year-old, there is a Doppler which has been done. Very happy to see 28 online viewers today sitting at the comfort of the home and attending the mock test discussion. So what do you see here? Typically if you find a tongue-like pattern, that means a severe aortic stenosis. Right? So whenever you do the pressure calculations, so aortic stenosis typically will lead to left ventricular, severe aortic stenosis, left ventricular failure, and left ventricular failure will lead to pulmonary edema, and that lead to bibasilar crepitations is what you need to remember. So whenever severe obstruction is there, typically the maximal velocity occurs in the later part of the systole and the curve is more rounded in shape. Whereas if it is a mild obstruction, the peak is in the early systole. That is the reason there is a triangular shaped curve in aortic stenosis. Then whenever there is a subaortic obstruction is there, which is more like your hypertrophic obstructive cardiomyopathy, then there is a late peaking velocity curve, which is typically concave upward, is the typical feature, is what need to be understood. Now doctor, a patient is having pneumonia and a murmur is heard. 2D echo has been shown. So what are you seeing on the 2D echo? Typically you are seeing the presence of regurgitant jet. So, what type of murmur is a typical feature in case of regurgitation? Typically a murmur which is louder when the patient is in the left lateral position is the classical feature. So, dynamic auscultation of the murmurs. How do you differentiate a MVP murmur? MVP produces a late systolic murmur. Then aortic stenosis produces a ejection systolic murmur. So, how do you differentiate aortic stenosis murmur from that of a systolic murmur of HOCM from that of the systolic murmur of MVP with MR? So, all these are there in a 30-minute video called Dynamic Auscultation of Murmurs in the anatomy-to-medicine.com. What will happen when you do Valsalva maneuver, everything. So, wherever you are falling short, doing the questions wrong, immediately you can go back to the question bank, video library, and then review that particular video. Bus, 15-20 minutes you spend time on that. We have got theory videos, MCQ review discussion videos, topic wise. Both the things are available in the anatomy-to-medicine.com video library. Now a 79-year-old admitted to coronary unit with the unstable angina. Typically she has got a given a medication to decrease cardiac risk, and her ECG is being shown. What is the most appropriate treatment? So there are no P waves accompanied by QRS, right? Some only the absence of the P wave is the important indication of the lack of atrial electrical activity which occur in atrial fibrillation. So there is something called as a CHAD scoring system. So to whom do you want to give anticoagulation? Whenever they have a atrial fibrillation, there is a chance of embolization and developing stroke. So the risk of the stroke in a person with atrial fibrillation is assessed by calculation of the CHAD-2 score. So based on that we take a decision whether to give the warfarin forever or not. So the CHAD-2 score is a very quick technique by which you can, if the patient has got congestive heart failure, if he has got a hypertension, if the age is more than 75 and diabetes and a previous stroke history. So that typically makes CHAD-S2 score, which is an important indicator, gives an indication for starting anticoagulation. A 55-year-old has just arrived to the emergency, 20 minutes of central crushing pain. What is a very important indicator of all that says that MI? Any given day it is a ST segment elevation. You won't give a thrombolytic therapy unless ST elevation is there. If there is no ST elevation, there is no indication for thrombolysis, right? But there are certain things which are called ST elevation equivalents. Suppose if a new left bundle branch block develops first time, that's the reason whenever you are a house surgeon in the casualty, you should ask, please show me your earlier ECGs. So if you check earlier ECGs, you should look for the LBBB. If the LBBB new onset is being discovered, it is called ST segment elevation equivalent is what need to be remembered. But ST segment elevation is the indication for starting the thrombolysis. Otherwise you will give MONA, morphine, oxygen, nitrate, aspirin. That is the standard treatment, right doc? So, Vijay Lakshmi, 66-year-old, comes to emergency, becomes progressively short of breath. She also has a pain in the right leg. And what is her ECG showing? In the lead 1, after the positive R wave, there is a negative S wave. So S1. Then in the lead 3, there is a deep negative wave, which is Q3. And there is a T wave inversion, which is T3. S1, Q3, T3 is called most characteristic feature of pulmonary embolism. But examiner will also ask a question. What is the most common finding in pulmonary embolism?